Mhm.
Yeah, Gaurang Shah, sir, good evening.
Good evening, Dr. Balaji. Gite Saab, good evening, Mahendra.
Yeah, good evening, sir.
Sir, good evening, sir.
Good evening. I think we might have to start. I had a discussion with even Sujata also. In fact, I requested her that your program is exactly on Tuesday, 8 to 9:30. And actually, we started our program much earlier. But this is an ISU program. So, by the time they finish, 9:15, 9:30. So many students, they join after this program.
तो थोड़ा 10 मिनट रुकते सर, कोई प्रॉब्लम?
हाँ, 10 मिनट रुक के, and we'll put it on this group also that they can, if everything is over, they can leave earlier and can join.
नहीं सर, इसमें कैसा है कि हम किसी को फोर्स नहीं कर सकते।
Yeah. No, we will
नंबर
say.
2 है कि किसको 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 कौन से टाइम को पढ़ाना है, वो हर एक की अपनी अपनी मर्जी है।
No, nothing. I agree.
But पढ़ने वाले के ऊपर है किधर जाने का।
And I agree, but it was the same timing was there, so I had requested. Anyway, it is up to them to decide.
एक्चुअली क्या है कि लास्ट 4 साल से हम ये प्रोग्राम कर रहे हैं, जबकि ISU का प्रोग्राम शुरू नहीं था।
Correct. No, just see what happened. That USI ka two programs were together. One was WOU, Women Urology Organization, and second was, one second, apna ye on malignancy. So both were on the same.
वो तो डेली एवरी ट्यूसडे नहीं रहेगा ना?
No, that program, what I'm saying, that USI only had both the programs on the same day.
Tuesday.
Women Urology Association and this thing, onco section. Both the section had the same day, 26, 27.
But is that program is on every Tuesday? It is not related to our...
No.
Nowadays,
No.
Sir, nowadays there are so many programs now that everybody is confused what to do, where to do.
No,
I am saying coordinating. Yeah.
I am saying USI is not coordinating. There are two
Correct, sir.
programs. Two conferences were on the
on the same day. Yeah.
And second in Ahmedabad. Both subsection of USI, they were on the same dates.
So that we have to communicate with.
USI, see, if people, they want their program, like, it should reach to everyone properly. We have to coordinate. Every one of us have to coordinate.
Correct.
That is the only thing, nothing else. It is just to streamline the USI. Just in USI only the same thing happened. Just imagine two subsection having the same time.
कैसा है सर कि अभी everyone want to do the program and everyone want to teach. So,
Yeah. So that is why we have to streamline, nothing else.
हाँ, तो वो स्टूडेंट्स ने डिसाइड करना है कहाँ जाना है.
Yeah, that is true.
क्या हाल है महेंद्र भाई?
हिरेन भाई सब बढ़िया। आप बताओ।
बहुत दिन से बात नहीं हुई।
हाँ, 2 बार से जरा कुछ आई वॉज आउटसाइड मुंबई, तो प्लान नहीं बन पा रहा
अच्छा
था।
अच्छा।
आई मिस बोथ द लास्ट 2 ट्यूसडे क्लासेस।
वी ऑल्सो मिस्ड यू।
या अभी जस्ट एग्जाम खत्म हुए थे बेटे के, तो वहां गए थे।
ओके ओके।
फिर सम फैमिली कमिटमेंट्स एंड लाइक दैट।
राइट राइट राइट। गुड टू हैव यू ऑन बोर्ड।
या
So Mahendra,
हाँ सर।
today now we will have the 3 cases.
हम्म
Today only one case. Today it will be muscle invasive. Then we will have superficial and then metastatic. We will arrange that way. So the 3 cases of like CA bladder.
ठीक है।
So now we are
ओके
going to take after that maybe CA prostate, then CA penis, testes, all this we will finish as early as possible.
ओके, नो
Okay.
इश्यूज।
So I'm just calling Ganesh. Ganesh is joining in 10 minutes. He has got some last moment preparation for the flights. They have cancelled his flight last moment. So he is doing some arrangements.
ओके।
Sir, who will be answering today?
Yeah, who is answering? Who all are answering? I think
Dr. Suhas and Dr. Santosh have also joined. Please make them co-host.
They are answering?
Yes, sir.
Where is Santosh? Santosh is by which name? There is no, I cannot see any Santosh. He has joined by which name?
I'm just asking him, and I will message on the chat box.
So just a suggestions, few suggestions for who are presenting the case. Just focus on the complaint and don't focus on the diagnosis at present. If you focus on the complaints one by one and make a sequence of that, automatically you will reach toward the diagnosis. So hematuria doesn't mean only bladder. So go with the flow of the history and the complaint.
Last
Sir,
class
I
only,
thought-
Mahendra.
क्या हिरण
Mahendra
भाई?
bhai, last class, na Mahendra bhai.
हाँ.
We have told them that you go from kidney to meatus or meatus to kidney. So follow that protocol.
Yeah,
वही
बिल्कुल,
बात आपने
बिल्कुल.
अलग से बोली है कि hematuria doesn't mean only bladder. So let them go through it nicely. And
हाँ. So
we also told them that two other things, that whenever there is hematuria, then you should have that set of questions ready, whatever you have to ask. Same way, when you have low urinary tract symptoms, you go through all the symptoms. So
yeah, so
that way just streamline the flow.
So yeah, so sir, just elaborate this thing. I just made a new teaching method of teaching the how to learn that. It is
Yeah.
that from history to diagnosis to follow up is like a pyramid, where
Correct.
the follow up is the top, and the history is at the and complaints at the base of the pyramid. And
Right.
step by step, if we go, it is a history and the complaints, then examination, then investigation, and remember oncology. In oncology, after the diagnosis, remember carefully, after the diagnosis, the first job is nowadays to stratify as per the risk criteria. Only after that, all managements are depends on the risk stratifications. So wherever it is,
Perfect.
do that thing. Then you go for the management, and after management, whatever the options are there, maybe combined, maybe multimodal therapy or whatever surgery and whatever it is. Then after the biopsy report, high risk or low risk, whatever, follow protocol. So this is the pyramid. If you go like this, you are never going to miss anything.
So let's take them through that. It's good idea, very good suggestion.
Yeah.
And like sir discussed, we'll take all the scenarios one by one.
Okay.
Yeah.
I think 24 people has joined. Shall we?
I think we can start now.
Sir,
can
Dr.
start.
Hamid, Dr. Santosh, and Dr. Suhas, they have been made co-host. They are the volunteers.
So who is presenting what?
Dr. Hamid, Dr. Suhas, and Dr. Santosh will answer the Viva.
Okay, who is presenting the history? That we can ask
Brijesh.
anyone.
Brijesh.
Okay.
Yes.
So Suhas, Hamid, and the third one is
Santosh.
Okay. Take.
Brijesh bhai ready, no?
Yes.
Yes, sir.
Okay. When sir, yeah, good evening. When sir says, then we start. Okay.
Malini. I think we should start now. People will join. Okay.
Okay, sir. A 74-year-old retired male patient presented with a complaint of painless hematuria since 1 month, burning mixtures and increased frequency since 15 days.
Yes, Santosh.
Sir.
Yeah. See, these are the complaints. Now, what are the questions you want to ask?
So,
Want to
sir, I want
elaborate
to just
Sir,
I want
yes.
to interrupt. Just by seeing this history and this, so whatever you have read till date, what things come in your mind first? Painless hematuria, body micturition, increased frequency. Because based on that imagination, you are going to ask questions. Did you get my point?
Yes, sir. Yes, sir. It's an elderly male patient with painless hematuria, sir. So it can be a malignant cause, sir. That thought I got in the mind, sir.
So you think about the malignancy, and as an oncologist, I thought about the organs from where hematuria can arise.
Sir, liver urinary tract, sir.
The biggest mistake you all are doing, you are just reaching diagnosis at the beginning. What I said, focus on the complaints and the history.
Yes.
Okay, go ahead.
Bladder, sir.
Santosh, have you understood what Santosh is saying? Mahendra is saying. Dr. Mahendra is very specific. That means you are thinking only of malignancy. But it can be painless hematuria can be because of different organs, different diseases.
Yes, sir. It can be due to anticoagulation. It can be due to.
My advice to everybody, by only knowing the history, never try to reach towards diagnosis.
Okay.
At least one diagnosis, never. It will only bias you towards that diagnosis, make you biased.
Okay, sir.
Yeah. If you think by luminal thinking, then it will happen. Whenever same patient came to you in your casualty or in your OPD, there should be some 3-4 diagnoses in your mind. Until then only you can ask the negative question. If you think it is a CA bladder, then that is wrong. You think in a broad way, old age, painless hematuria, क्या क्या हो सकता है, पेनलेस है नहीं है वो अभी कंफर्म नहीं है, वो बोला है उसने पेनलेस है बोल के है.
Yes, sir.
So don't get confused. What teachers are just trying to say is that you need to think broadly. Everything from kidney to outside, whatever comes in your mind. That is what we want to emphasize. Okay?
Okay, sir.
क्योंकि एग्जाम में वाट महेंद्र सर बोल रहे वैसा ही हो जाता है. लोकल का कोई आदमी आके डायग्नोसिस बोल देता है या ढूंढ के तुम निकाल लेते हो और फिर वही टारगेट करते करते कहीं पे फंस जाते. तो इट इज बेटर कि वो तुमको डायग्नोसिस पता नहीं, तभी तुम ब्रॉड वे से थिंकिंग करेंगे.
See, the first thing is painless hematuria. Now, what is the second symptom? Burning micturition and increased urinary frequency. Now, if you consider two different diagnoses, is a different thing. If you think of one diagnosis giving these two problems, you understand? Then it is a different thing. Okay, so okay, go ahead. So now tell us everything about hematuria. So you should say, sir, this 74-year-old male presented with painless. According to the history, it was a painless hematuria. I will like to know following things. So now tell us, what are the things you want to know?
Sir, I want an elaborate. I want to get elaborated details related to hematuria, sir, onset, duration, and progression.
and whether is already mentioned it is 1 month and it is painless, and I want to know whether it is associated with any clots, and I want to know whether it is continuous, terminal, or initial, and I want to know whether the patient is having any history of fever or lethuria, trauma, or instrumentation. I want to know whether the patient is on any anticoagulants, sir. Already, a history of FACULTIES already it is mentioned is having burning micturition and increased frequency since 15 days. I want to know whether the patient having any flank pain, sir. Yes, sir.
Okay, so you asked about the clot. So what specific you would like to know about the clots?
Sir, any any shape of the clots, sir, or is it it's having it is having an association with any tissue uh, along with that passing
Tissue along with the clot.
small. Yes, sir.
Okay. So what does it mean? Tissue along with the clot. This is not a shape of clot. This is the clot consistency.
Like
So clot either large clot, amorphous clots, छोटे clots होते हैं, या फिर thread like, right?
Yes,
like
sir, yes,
earthworm like clot or thread like clot.
Yes,
okay.
sir, yes.
So which structure in the unit tract will make the thread like clot?
Upper tract.
Upper tracts.
Upper tract from the pelvis or the ureter, because if the pelvis large clot is formed, it will not come into the ureter. But
Sir.
if it's a very slow bleeding, it may form the clot. Amorphous and the large clot found in the only bladder.
Yes.
Or maybe very small bleeding from the ureter that not that sufficient, which can make a thread-like clot.
Yes, sir.
Okay, this is how you should tell about the characteristic of the clot, which will guide you the site of origin.
Yes.
And also the colicky pain. If colicky pain with clot hai, again it is upper tract. Bladder mein nahi hoga colicky pain. Okay.
Yes, sir. Yes.
Yeah. So I think, or again hematuria, आप stone भूल गए कि any history of passing stone, जो general causes है वो आपको पूछने ही पूछने.
Lethuria, yes, sir. Yes, per Lethuria. I asked
you asked.
Lethuria whether.
Yes. Okay, maybe I missed that. That is fine.
And
okay.
flank pain also, yes. Yes.
Yeah. So to complete that, you can also ask about the trauma, which is not there, but you should ask.
Yes, sir.
Just to complete the history.
Or instrumentation. Yes.
Yeah. Okay.
Patient was asymptomatic before 1 month and noticed passing of blood in the urine, suddenly onset, painless, non-progressive. Hematuria was complete, intermittent, associated passage of amorphous fluids. Patient had burning micturition with increased frequency since 15 days. Quantity score is also mentioned. Symptoms were insidious, gradually progressive with no specific aggravating or relieving factors. So there was no history of lethuria, no history of colic pain at the time of hematuria, no previous instrumentation or catheterization, no jaundice, facial puffiness, nothing, no back pain, no bleeding disorders, no anticoagulant therapy, no history of radiation or chemotherapy.
Okay, just for clarification, you also mentioned the history, the terminal, initial, and the complete hematuria. What does it mean? Or what does it indicate?
If it is initial hematuria, then it is the initial pain. I mean to tell it is if it is continuous, the origin will be from bladder, sir.
And if it is initial,
then the origin can be from the urethral. Yes, sir. And if it is terminal, then can be from the prostate.
Or trigon. Terminal generally
yes.
from the trigon, actually, when the bladder squeezes the things because of contraction. Okay.
Yes.
Okay.
So how will hematuria from BEP appear? This is all like...
Sir, good evening.
Good evening. This was like from the calculi or bladder or upper tract, but very commonly hematuria is produced because of just prostate, enlarged prostate, which may be inflamed with capillaries on that. So how would that hematuria go?
And what is the association of clots with that? I'm sure most of us would have seen such patients.
Mostly continuous, sir.
So these are the practical questions.
Because
When you answer these
74-year-old with
questions,
hematuria, BP
yeah,
is the most common, one of the most common cause.
Yes, sir. Yes, sir.
so just tell what you have seen in your clinical
Oh, sir.
examination.
Continuous, sir, mostly. Or
Many times such
It is
patients
post.
present with clot retention also.
Yes, sir. Clot retention. AUR.
Right. So prostate bleeding usually because the sphincter is distal,
Yes, sir.
that kind of bleeding goes and mixes with the urine, and it is presents almost like a bladder-based hematuria. Now the type of clots like bladder are going to be kind of amorphous only. They cannot be long clots.
Okay, sir.
So remember, BP is one of the cause. Like,
Yes,
please
sir.
go ahead.
We'll ask about the patient's past history, sir. Any previous similar episodes, or any history of any positive family history, like any history of malignancies. We'll like to know, sir. Then a personal history. I'll ask the patient related to the diet, sleep, appetite, bowel habits, and addictions specifically. And yes, sir. And previous history of surgeries, sir.
The patient had a history of hypertension since 15 years. He was on tablet telmisartan. He has non-diabetic. Family history was not significant. Bladder activities were altered because of the urinary symptoms. He had no addiction, non-alcoholic, and non-smoke.
Amit, you can also answer, huh? All of you are supposed to answer. Santosh,
Sir.
Santosh, Hamid, and Suhas. Suhas, where is the Suhas? So
Yes,
Suhas,
sir, I'm here.
yeah. So now this is a history. So
Yes,
depending
sir.
on that, now what is your probable diagnosis? What comes in your mind when you see when you hear about such a history?
Yes, sir. It being a painless hematuria, sir.
See, in the beginning, he has told you two different history, correct? He has talked about lower urinary tract symptoms. Also, he has talked to you about a hematuria, painless hematuria. So now in
Yes,
your
sir.
mind, it comes whether there are two different entities or whether it is one which is giving two symptomatology.
Yes.
Yes, sir.
So can you think like that? So what are tell me two different things and tell me one thing which can give rise to both the problems.
So one, as sir said, BPH can present with both LUTS and bleeding,
Okay, so
painless hematuria.
you're talking of one disease giving rise to both symptomatology, right? So one, as you are
Yes, sir.
saying, that, don't say BPH, enlarged prostate.
Enlarged
Terminology
prostate. Yes.
should be proper because that is histopathology diagnosis. Say
Yes, sir.
enlarged
Yes, sir.
prostate, right? So there can
Yes,
be
sir.
enlarged
Yes.
prostate, which can be because of malignancy also. It can be because of just a benign enlargement of the prostate. So that is number one. Second,
Second one is uh, from carcinoma bladder, sir.
Hematuria due to malignancy, sir.
Malignancies.
so single diagnosis is malignancy, but where?
Lower tracts, sir. This can be a
From the
bladder.
histories, it is complete hematuria, yes. So I would consider upper tract also. Upper tract bar or the urinary bladder
So if you're talking of
associated
upper
with
tract, then it cannot give rise to burning micturition,
with
correct? We are
With
talking of
okay,
single.
sir.
You are saying single,
Yes, sir.
and you are
Okay.
talking about cancer of the bladder. So if you are talking any
Okay.
growth in the bladder, where it should be, then it will give rise to LUTs also and hematuria also.
Near the bladder neck
If it is involving the
or
trigone
the prostatic area.
in gluteus.
Yes. So say like that. Okay,
Yes, sir.
Yes.
fine. And what are the two different entities you are thinking of?
Prostate and bladder, sir.
Bladder, prostate and bladder.
So bladder outlet obstruction, it can be because of anything, correct? And second is malignancy. So malignancy can be anywhere. It can be in the kidney also, it can be ureteric also, it can
Lower
be
tract.
bladder also, or it can
Yes.
be,
Yes, sir.
right?
Yes.
Yes, sir.
Something like that logically. And now you tell us what are the investigations you want. Or sorry, before that, what you want to do now?
I would
To examine
like to
the
know his
patient, sir.
personal history, like is he a smoker, or he having family history of this CA prostate or CA bladder?
Nothing. It is written, no? Family history not significant. Habits, he has no addiction, non-alcoholic, non-smoker, everything is given. History is complete. So now next, what you
So
want to
then
do?
I would like to do like extend my clinical examination with the sonography to just
Before that, you don't want
look.
to do any examination.
General examination we like
Abdomen
to do,
exam.
sir.
See, this is what happens in exam. You may be knowing everything, but suddenly when the examiner asks you, you skip something and go ahead. Suddenly the examiner will ask you, okay, now what surgery you want to do? Now there is something in your mind that you know this is say a bladder, and then you will start talking about that. Go very
Yes, sir.
systematically. Okay, chalo. Tell us.
So on general examination, patient's weight was 60, pulse rate was little bit tachycardia, blood pressure was 106/70, and there was evidence of pallor. Or otherwise 8 to 2 examination was normal.
So what is the meaning of this? He is telling you that pulse is 106, BP is little on the lower side, 106/80 in 74 years old male, and there is evidence of pallor. Now what
Patient is
is the meaning
bleeding
of
more,
this?
sir.
Pardon?
Patient is having more blood. I mean, patient is bleeding more, hypotension. He's in little bit of hypotension and pallor, anemic, sir.
So what you will, if such a patient comes to you in your OPD, what you will do?
First, we would like to admit the patient, sir.
Very good. Correct. So that
Yes,
should
sir.
be, these are the small catches, which you have to, because every case will not be the same. If you get such a case,
Yes,
then
sir.
this is the answer. You must say,
Yes,
okay,
sir.
sir, I like to admit this patient.
Yes, sir.
Fine. Go ahead.
Would like to do a perabdominal examination.
Yeah. Brijesh, go ahead.
Per abdominal examination was normal. No any swelling, no any lump or suprapubic mass palpated. Everything was normal.
So Hamid, you tell us what are the important findings you will look for.
Sir, if
PR was
hematuria is from
done.
upper tract
PR,
and
rectal question was done. PR was not
I'll
done
just
in this case.
examine the patient from abdominally and then suprapubic if the patient bladder suprapubic I will examine, and then local examination I will see the EUM and testis and DRE, sir.
That is already not palpable. So we'd like to do the DRE, sir. to see the prostate enlargement, if any prostate enlargement is there.
This is an answer. The PR is normal. It is a grade 1 prostate.
Yes, sir.
Yes, sir.
No, what I'm asking you, what you are means what are the important findings you will not like to miss in your systemic examination? See, as you are saying that this patient has bled quite a lot, correct?
Yes,
So
sir.
there are chances that there may be a clot retention. And in that case, you may be able to palpate bladder.
Super.
Yes.
This is just for your information. Go ahead. Okay. Brijesh. Okay, fine. So now this is the examination. Next, what? What do you like to do?
Would like to investigate the patient, sir, with like general routine investigation like CBP, as the patient is already anemic, and renal function test, CUE, and urine culture sensitivity. Along with that, would like to do the specific investigation like urine cytology. And as an extension of my examination, would like to do this ultrasound KUB, sir.
Okay.
Show them.
So this is urine routine micro. There are pus cells, which are 8 to 10 per high fervent innumerable RBCs. There is albumin leaking in the urine. Urine culture was negative for any growth. In urinary cytology report.
No malignant cells.
I don't understand.
Ultrasound.
This was the blood report. Hemoglobin was 6.6, WBC
Hemoglobin
count
is
is
6.
5,000. Serum create was 1.29 and HbA1c is 4.7. INR was normal.
Ultrasound.
Any one of you can comment, please.
This is ultrasound of abdomen, sir. First plate, you can see that liver is looking normal, sir. And second plate, bilateral kidneys. One kidney is dilated, sir. Exactly the leaking system is dilated in one kidney, sir. And there is in bladder, there is a mass.
Do you know how to read
And
sonography? The organ site, upper pole, lower pole of the kidney, medial, lateral, bladder neck, posterior wall, dome. Do you know how to read on CT under sonography? What is upper and lower pole of the kidney? So the left one is upper pole, right one is
left
lower
one is upper
pole.
pole and the right one is, yes, sir.
Yeah. And the pelvis, pelvis is always medial, and the white is a sinus fat. The white one, if you see the second photo, the bright fat is the sinus fat, and the cortex is over there. And in the bladder, on the right side, you will see the bladder neck and the prostate, and the left side, it is the dome. Base is definitely inferiorly, and the anterior wall is above. So this mass appears to be anterior wall mass, I think so. And the lot is the last picture, that red one. What is that picture is?
Is that Doppler?
Doppler, sir.
Yeah. So there is some vascularity in the mass. Okay.
Mass.
So now by this sonography, what picture you can make? What are you dealing with?
A bladder mass. Ready.
Only bladder mass, something else?
Bladder mass.
It is a bladder. Sorry, it is a bladder mass with one kidney
in-
showing hydronephrosis and probably hydrouretero
Involvement of
also,
the
and
urethritis.
the mass is obstructing one VUJ, causing that hydroureteronephrosis.
Okay. Okay. Fine. So what next now?
So based on this ultrasound finding, we would like to investigate further and would like to do contrast enhanced CT for the patient.
Okay. So there are examiner may confuse you like that. There is a bladder mass. Why do you want to do a CT scan? Why don't you want to prove it? That is a cancer, then do a CT scan.
Just to see if there is any involvement of upper tract or any lesions in the upper tract. It can be like TCC.
Yeah. So why not biopsy first, then to CT scan?
There is hydronephrosis in this case.
It will distort the anatomy.
CT cannot be done immediately after the biopsy.
Sir, we have to plan accordingly for the surgery. If we have to do just we have only to do with the lower tract, or we have to address upper tract as well.
No, I'm saying your plan is okay. I'm just asking you, just confusing you how to answer in the exam. Examiner may confuse you. Why don't you do a biopsy first, prove it as a malignancy, then do a CT scan?
This question is very simple. Can you do cystoscopy and biopsy without doing CT scan?
We can, yes, we can do that.
Answer is like this: whether
In other words,
case,
in this case, why do you want to do CT first? Is there any evidence on sonography which makes you think that you should do CT first?
Hydronephrosis.
So what are the indirect signs of invasive mass?
Hydronephrosis is
Cytology.
it's muscle invasive, sir.
One is hydronephrosis.
Cytology
Second
positive.
finding.
Cytology positive.
No, you're talking about ultrasound. No? Let's finish ultrasound.
Ultrasound. Okay, sir.
On
Yes, sir.
ultrasound, what all signs are there? One is hydronephrosis, you said.
One is
Second, broad
hydronephrosis.
mass, 5 centimeter mass, multiple masses, mass going outside the bladder. All these things, no?
Yes.
Yes, sir.
Yes, sir.
Large mass,
Possible,
more than 5 centimeter
possible
mass.
extension of
Lymph
deep
nodes.
extension of the tumor, large mass, hydronephrosis.
Correct.
Possible upper tract tumors, we have to do.
So
TCG.
now you all answered already by yourself, okay? But don't answer that in USG it is reported CT abdo-pelvis for further evaluation. This is not the reason you do CT scan first.
Yes, sir.
Yes.
Yeah. Okay. But creatinine is 1.29. Is it safe to go ahead with the CT scan?
Yes, sir. Till 1.5,
Yes.
we can go ahead with CT scan with the proper hydration of the patient.
Yeah. Okay.
But the recent EAU guidelines mention you can do an MRI. So why are we doing CT scan? Why not MRI directly?
yes, Amit, Santosh. Sir has asked you this question, and we were debating this. Means he has taught us and told us last time also, but still it was not in a practice. We had discussed about Virat.
CECT can do the better staging. It's a better staging tool, sir, than MRI.
MRI gives much higher resolution, and EU guidelines do mention them.
So, Ganesh, what is the new EU guideline? Just tell us.
I'll just try to download and put it on the group.
Okay. But just tell them about the BIRAD, na?
So IRADS 1 and 2 is like we don't even say there's a possibility of a tumor. IRADS 3 goes borderline. 4 and 5 we definitely say that it is a muscle invasive ahead. Where MRI scores over CT scan is better if you have a T3 or a T4 tumor. MRI scores at the T2 level. Much better for a local staging than CT scan. The T2 weighted imaging shows a muscle as a dark layer, and till now we were like having a debate, CT, MRI, which is better. There are some fallacies to the MRI. It should not be post-surgery bladder, post-TURBT bladder, post-probably BCG bladder. These are the things. I mean, any of you have EU guidelines recent? I'm sure who. I'll try to put it on the group, but whoever has, you can put it on the group.
Yes.
Let's
CECT.
go ahead.
Bridges, go ahead. Now, we had asked for a uroflowmetry. Is there any role of uroflowmetry? And suppose if you say in exam, how will you define?
Patient had lower urinary tract symptoms also, sir. So to rule out the renal prostatic enlargement causing, it's not there in the examination, but as patient presented was having LUTS.
No, you did not classify LUTS obstructive or irritative.
Yes, obstructive LUTS.
Though I don't know what is the current role of uroflowmetry in irritative voiding symptoms. I think it is more informative for obstructive LUTS, not the irritative one.
Yes, sir.
Maybe I'm wrong. Gaurang Shah, sir, can you just tell this answer of this question?
So we should evaluate the complete LUTs, and the correct terminology is voiding and storage LUTs. So storage LUTs also gives us information about the bladder, and voiding LUTs gives us the information regarding the obstruction and severity of the obstruction. So all 7 symptoms have to be evaluated whenever there is a patient with LUTs. And the ICS nomenclature is voiding and storage symptoms.
So in case if there is a lower intake symptoms, by asking for uroflowmetry in 74 years old male, you may not be wrong. So you can always justify, okay, that's see, patient is 74 years old, he has got lower intake symptoms, and many a times the storage patient may have more of the storage symptoms, but it may be associated with the obstruction which can be diagnosed by uroflowmetry. Because many patients, that stream may be very weak, still they are very happy, and they will not. If you sit in OPD and if you see multiple uroflowmetry and correlate with the clinical symptomatology, you realize many patients, they come and say, no, my flow is very good. But when you do uroflowmetry, you really, will get surprised that how come he is telling that he is passing urine very well. Fine. Bridges, go ahead. first ask for all the films. Brijesh, show them all the films. You see that carefully and then answer. Amit,
So this is the axial film, the CT scan film, showing both the kidneys, left kidney showing moderate to gross hydroureter nephrosis. Parenchyma on both the sides are normal. Uh, there is a mass in the bladder at left posterolateral wall extending up to the lateral wall of the left side. It seems muscle invasive on the scan.
why you are saying it is muscle invasive?
It is a broad-based lesion, and uh,
Now, what can be the cause of the hydronephrosis?
it may be obstructing the VUJ or involving the VUJ, leading to the hydronephrosis, hydroureter nephrosis.
Yeah, so most of the time, such a big mass must be involving the ureter, correct?
Yes, sir.
Yes.
So then it becomes a muscle invasive. So that is why one
Yes.
probability. Second thing, you see the fat around that. Can you see?
Yes,
Fat
sir.
standing.
You can see that it is going right up to there.
Yeah.
Mahendra bhai, you want to, give them some guideline how to go about whenever they are reading,
Yeah, so
like in
first
a
of
CA
all,
bladder.
yeah, the generally mistake they don't include the area is covered in the on the CT scan. It is a abdo-pelvis, whether contrast or non-contrast scan. And in this description, the person described from effect to cause. Ideally, it should be a cause to effect. Like first, you describe the CT scan, the area, abdo-pelvis, contrast enhanced. Then I can see the enhancing heterogeneous enhancing lesion in the bladder involving these wall. It has two lesions. The right wall is also involved. Right posterior lateral wall also involved in the CT scan. If I can see, which is involving the entire lateral wall and the part of posterior wall with some perivesical fat is trending, resulting in the and also having the hydronephrosis, which is then it is indicating the muscle involvement and the perivesical fat is trending. These two features are indicative of muscle involvement. This is the way how you should describe. It should not go from effect to cause. It should be from cause to effect.
That's good.
Okay.
And so again, you should know in each CT scan and each organ what specific things you have to see. Like TNM staging, you describe the T stage. What about the N stage? You did not describe about the pelvic nodal status. Can you see the any pelvic nodes? External iliac, internal iliac obturator node, common iliac nodes, or RP node? You did not mention that.
Yes, sir.
For M staging, what do you want to do? M staging?
For metastatic workup, I would like to do HRCT test along with that.
So always malignancy में you have to do a complete workup for metastasis, which is generally not done in the benign diseases.
Yes.
Yeah.
Brijesh,
Okay.
just show them HRCT also. What is the report?
There are patchy areas of ground glass attenuations and interlobar septal thickening in upper lobes. Right is greater than left. In both lower lobes with mild left and moderate right pleural effusion in view of bladder region, lymphangitis, carcinomatosis. The possibility of fluid overload cannot be completely ruled out.
Yes. So Amit,
Yes, sir.
so now what is your inference? Now what you want to do?
So,
There are some anterior wedge compressions and fractures of D6 and L1 vertebral bodies noted.
Any one of you, please answer. Show them a CT scan of abdomen and pelvis also.
The left kidney shows reduced enhancement and delayed excision of the contrast, moderate dilatation of pelvic system. Few subsides, sub-centimeter sized retroperineal lymph nodes can be seen in left paraortic regions. And urinary bladder is distended and shows evidence of multiple polypoidal soft tissue densities enhancing lesions along its anterior, bilateral, lateral, and posterior wall. Largest of the lesion is seen in left posterior lateral wall protruding into the lumen, measuring around 7 by 4.2 centimeters. It suggests, and there are hyperdensities seen in the lumen suggestive of blood clots, which may be seen involving left uretrovesical junction and with extension seen in the distal ureter causing proximal moderate hydroureteronephrosis. And there are wedged fractures, compression fractures, L1 vertebral bodies, and irregular osteolytic areas in D11 vertebral bodies.
Okay, fine. So Santosh, now what you want to do?
Based on this, the staging I will first see, sir. It is already emerging with its T2 and N2, sir, because it's telling multiple sub-centimeter bilateral internal as well as external lymph nodes. It also it is seen. So and in chest HRCT possible pleural effusion might be due to it, so it can be M1.
sir, this patient has perivesical fat space involvement also. So, shouldn't it be T3?
T3.
So what is the difference opinion between three of you? T3 है, T2 है, T1 है, T4 है.
It should be T3, sir.
So image दिखाओ वापस.
T3A, sir.
So what is the prostatic involvement from a bladder?
If this prostatic stoma is involved, then it is
Stoma.
T4A, sir.
T4A.
Prostatic involvement if it is only urethra then?
TIS, sir.
Huh?
TIS. Sir.
TIS. Okay. It's a bladder cancer, no? If that spreads say and goes
Then it is M1.
from the
sir.
bladder
Yeah, it is
neck
bladder
onto
cancer.
the prostatic urethra.
Yes, sir.
It is TIS. Suppose if
No, it
T2
is
in the
not TIS, sir. Then
bladder.
it is a pelvic. Then it will be T4, sir.
Okay. Is it? Okay, and if that bladder tumor, which is supposedly T2 or T3 in the bladder, goes outrightly into the prostatic substance, then what it becomes?
If it is prostatic stroma involvement, then it is T4A, sir. If it is prostatic
So how will I know
urethra, then
prostatic stroma involvement on the CT scan or the whatever MRI? अभी स्ट्रोमा थोड़ी बोल के आता है कि सीटी स्कैन पे लिखा हुआ कि स्ट्रोमा. अभी महेंद्र सर ने बोला ना कुछ.
Yeah, it is T4A, sir. T4A it is.
देन अभी इसका इमेज देखो वापस. क्या दिखता है? वो रिपोर्ट में क्या लिखा था नीचे कंक्लूजन में? We are not seeing the slides, by the way. I think Brijesh had unshared the presentation.
We can't see the slides. Maybe he logged out.
Okay, so if we ask this question, what is the role of FDG PET CT? Chalo. Till the slides are put up. You read whatever report was there from the CT. Taking a cue from that. What is the role of FDG PET CT? When or when not? Why not?
So when we have to decide about the management of this patient, if the
Excellent.
patient is metastatic, so
When you have to
the
decide the
surgical
management for
treatment on
metastasis.
no,
If you want to
for
do
this
just the
patient, sir.
metastasis workup in bladder cancer, is it you need to always do a PET CT?
No, sir.
तो क्या करेंगे फिर बोलो?
But
but see, whatever you answer, try to answer confidently something.
so like if we have to decide about like if should we go for the surgical procedure or we have to give the neoadjuvant chemotherapy for the patient.
Okay.
Or
see what is the impression? Multiple polypoidal soft tissue density, enhancing lesions in urinary bladder, involving left uretrovesical junction. So what is that? That is a sign of indirect sign of muscle invasion with resultant proximal moderate. It is not mild, it is moderate hydroureteronephrosis with perivesical spread. That means CT is indicating. CT is a good investigation if there is a T3 disease or a T4
local
disease rather than T2 and T1 or differentiating between T1 and T2. So perivesical spread it is saying, and prostatic involvement with bilateral pelvic lymphadenopathy.
Ganesh, in fact, if it is showing that there is CT is showing muscle invasion, then we may not take even the biopsy from the muscle, right? Even if we don't get it, still be considered as a muscle invasive.
Sir, means we can consider. If it is T3 outrightly, I would be okay. If it is not outright T3, then we would still go in and do a TURBT.
Yeah. So in this case, what you want to do?
Sir, this case, मुझे पूछा है कि इनको पूछा है?
नहीं उनको आप पूछो ना उनको. What is their answer? Whether three of them are agreeing to each other or they have got a different answers.
T3, sir.
आपका तो final आएगा हम लोग, because we want to learn now what to do next.
T3 and
You have
2.
to confirm the diagnosis. Biopsy.
So how will you confirm the diagnosis?
The cystoscopy with TRBT.
So now what type of TRBT you want to do? You want to do total resection? You want to try total resection, or you want to Just take a
No, sir.
biopsy, or you want to take even the muscles? What do you want to do?
No, I just want to confirm the diagnosis, just superficial to confirm my diagnosis, not taking the muscle is also enough, sir.
So
Muscle is not required.
Hamid and Rahul, they are agreeing with you.
Yes, sir.
So, what is the purpose of doing biopsy? What are you getting from the biopsy, and how it will going to help you for the further management? It is clear cut T3 disease.
Sir, we can get the histology of the
The grade of the
specimen,
tumor
and
can be known, sir.
if no
And variant.
histology, and if we can see the specimen or whatever the tumor it is it a chemosensitive or uh, non-chemo sensitive and
Chemo resistance.
chemo resistant? Yes.
So what will be chemo resistant for our knowledge?
Small cell.
Small cell is excellent. Neuroendocrine is absolutely chemosensitive.
Sorry.
Sarcomatoid variant of urothelial carcinoma.
Sarcomatoid variant. Sarcomatoid में भी कुछ तो देते हैं cisplatin etoposide.
Nested.
So one thing is squamous cell cancer. I mean common चीज पहले बोलो.
Yes, sir.
Second thing, I don't know, but adenocarcinoma. Okay, these are the most common. Baki variants are in still lesser percentage. And if I ask you a question, if you just want a biopsy, just for the sake of saying it is cancer, then if we have a say urine cytology which says some positive cancer cells are there with big nucleoli and a higher grade, is it okay if we give chemotherapy?
Or we should give chemotherapy as if we are planning for some surgical step, it will downstage the tumor and will be
My
helpful
question
in
is
better
about
dissection.
replacing that
No, sir.
cystoscopy biopsy
So
with
with-
urine cytology.
So with cytology positive, we can directly go with chemotherapy.
Or is there any reference for that?
With the cytology, can you diagnose the type of histopathology?
No, sir.
No,
No,
sir.
no, no. We need the histopathology. Yes, sir.
So if you want to search, question is very simple. That
Yes, sir.
depending on positive cytology, without doing any biopsy, can you start chemotherapy?
No, we need a
So we had
sir.
discussed this
histopathology
last time. For the
diagnosis.
same reasons which we just discussed, there can be a variant which may not be chemosensitive. And that is why it is advisable
sir.
to usually have a biopsy, even though it may be very obviously advanced or a regional bladder cancer.
Yes, sir.
Understood? So in
Yes,
exam,
sir.
always ask for the biopsy.
And this particular case, the impression of the CT scan is very specific. It has a moderate hydronephrosis, perivesical spread, prostatic involvement, although they have not described the prostatic involvement in the way which we want, but when CT scan says it says that line extending into the perivesical space involving the base of prostate. That means probably it has gone. Probably I use that word. Probably it has gone through the stroma. And considering T4A
Yes, sir.
with lymph nodes also, they have not actually characterized so well. Multiple centimeter and sub-centimeter. This CT
Bilateral
scan is very
internal.
substandard. They should have at least measured the short axis diameter of the biggest lymph node and present on which side. So if these things are there, then maybe you are supposed to go back to your radiologist and discuss that.
Yes, sir.
Because we need a significant lymph node for that. So this is a T4A disease for sure. Debate is about N plus disease. Secondly, then what else will you do in the workup? चलो मेटास्टेटिक वर्कअप में क्या कंप्लीट करेंगे? एफडीजी पेट करना है कि कुछ और कर सकते हैं? You can always say, we always told you so many times, in our institution, it is a protocol, metastatic workup is this. You can always say that. We are teaching you here how to answer in exam. Confuse mat hona. Or if you want to support that PET scan, which technically I will not support so easily, you will have only answer is a institute protocol, but there will be a lot of questions.
Yes, sir.
So in this case, we already done CCT,
already done the
abdomen
CCT.
package, and chats also
Yes.
we have done. So
Absolutely.
what extra
Yes, sir.
information you will get in FDG?
Nothing. You can check the bones, but for bones, you can also see alkaline phosphatase, which is usually raised when there are bone mets.
So in this case, it was showing some, I think, fracture or something in the bone, and we thought of just doing the bone scan also.
Okay.
Brijesh, can you just show that? So can you read it?
Yes, sir. So inhomogeneous increased tracer uptakes in T6 and T11 vertebrae.
Okay. So that means by the bone scan, at least the bones are normal. So Suhas, what is this 99M TC MDP? Huh?
Yeah. Suhas, answer beta.
वो
Yes, sir.
99M TC MDP क्या है?
So technician of phosphate MD.
MD is what? Master of.
Yes.
Oh, अपना MD is Doctor of Medicine.
Just read down. Procedure. Just read the procedure.
Methylene diphosphonate, sir. Yes, sir. Technician methylene diphosphonate.
It is written. It is
Yes, sir.
methylene.
So technically, one more
Diphosphonate.
question. What is a better bone scan than this? F18 bone PET fluoride PET is a much superior bone scan than this.
Yes, sir.
Not necessary, always to be done, but in many prostate cancer patients, it might even show, micro fractures in the bone, which are never seen with MDP.
Yes, sir.
So that is a very superior bone scan. So we have reached the end of metastatic workup. You said the treatment you would like to do biopsy and not TURBT.
Yes, sir.
Any particular reason for saying that?
So already it is T4A, sir.
Okay.
In
So what is
CT.
the plan?
And
What is your plan? You want to do radical? You want to do neoadjuvant? You want to do only radiotherapy, radiation therapy, and chemotherapy? What do you want to do?
it's a neoadjuvant.
Only neoadjuvant, or followed by that anything?
So in this case, still I have a doubt. So in the HRCT chest, there is again pleural effusion is there. And can we go ahead with pleural tapping and
Patient hemoglobin
if
was how
6.6?
much?
If you are
Then
having
6.6.
suspicion, you can always go ahead with pleural tapping and do a pleural fluid cytology.
Yes, sir.
so hemoglobin is so low, hypoproteinemia, he has bled so much. There are some chances of pleural effusion may be there. But anyway, as Dr. Ganesh Bakshi has told you, if you have got a doubt, you aspirate and send it for the cytology.
Yes, sir.
So now why you want to give new adjuvant?
Had this been a single, it been say 2 masses which are broad based, there is no hydronephrosis and the prostate was not involved, what would you have done?
Two masses with perivesical spreads are the same findings.
2 masses, Same findings nahi. Prostate not involved, no hydronephrosis. Perivesical spread is a question in the report. Many times the radiologist wants to place a question. Perivesical.
Okay.
So you are not sure of perivesical spread. Now this is a situation. What you like to do? The question is very clear. You want to do total TURBT, or you want to do stage TURBT, or you just want to take a biopsy? What do you want to do?
So total TRBT, sir.
Okay.
Or something else other than TURBT, which sir wanted to know actually this stage? How to differentiate between muscle invasive and NMIBC without doing TURBT?
MRI.
In the beginning only, Dr. Ganesh has told you, na?
MR, sir.
MRI.
He told you, no? When
MRI.
MRI is very
Yes,
important.
sir. Local staging. Local staging. T.
Yeah. So he said, na, that if it is BIRAD 1, BIRAD 2 in MRI, then you are 100% sure that it is not involving the muscles.
Muscle. Yes, sir.
Correct?
Yes, sir. Yes, sir.
So, okay. So in this case, you want to do, in that case, whatever the scenario Dr. Ganesh Bakshi has given you, you will like to do TURBT.
Yes, sir.
Fine. Okay. So now, Ganesh, go ahead, na, please. Dr. Ganesh. Mahendra, you can take the lead. Okay, Brijesh, do we have the biopsy report? Just show them. Okay, read.
The biopsy shows a tumor comprising of round to oval cells with hyperpleomorphic nuclei. Lamina propria invasion and retrodermal invasion is seen. High-grade papillary urothelial.
Yes. Now this is a finding. What do you want to do? Now this patient has got a big mass involving the bladder. He has got hematuria, which is so much of hematuria that patient has all the signs of anemia as well as, okay,
Yes.
affecting the cardiovascular system. It is invasive and it has got left-sided hydronephrosis.
Hydronephrosis.
Correct. And creatinine is 1.29, where the normal value is up to 1.3. And you have got this biopsy in your hand. Now what you want to do? You want to do something to the kidney, or you want to give chemotherapy, neoadjuvant, or you directly want to go and operate?
So iska creatinine was 1.29, na?
1.29. 1.3 is normal in our institute.
Okay. So sorry, I had gone to the washroom.
Yeah. So these are the, I just told them that we are giving them three options, whether they want to give neoadjuvant therapy followed by they want to do radical, or they want to do anything else they want to do, because there is a hydronephrosis on the left side. They want to tackle it first, or they want to directly.
So options are how much? First, you have to decide whether you would like to give neoadjuvant chemotherapy. Okay. Neoadjuvant chemotherapy evidence is Vesper study. It is usually given with dose dense MAC. But in routine real world practice, neoadjuvant gemcitabine plus cisplatin is given. Now, when you talk about cisplatin, you need to think about cisplatin eligibility. So there is a criteria for that. I hope you know that.
Yes.
So with that criteria, again, we will have to see if our patient fits into that. So technically,
Yes, sir.
you should calculate an eGFR. If that
Yes, sir.
eGFR is allowing you to put this into cisplatin and gemcitabine, this patient should go into gemcitabine cisplatin. Now, if that eGFR is not allowing you to put him into gemcis, then there are two options. One, not very wishful option is, but we do it often, is you can always do a PCN on the left kidney, de-obstruct. You expect that whatever is the infected urine, and as such the kidney gets relieved. So the creatinine should fall further. And the third option
Yes,
which remains is if you don't want to do that, then you have to go with explain the patient, counsel. Counsel about what? Counsel about surgery, counsel about the extent of surgery, and counsel about the role of adjuvant chemotherapy, and then go in and do the surgery. So
See, yes, explained you so well. Now,
these are the
I
three
want
options
all
which
three
sir
of
was
you to
asking us.
decide. I want all three of you to decide one management and tell us. So, Hamid, you tell us which management you want to follow.
Sir, I would like to do neoadjuvant chemotherapy followed by radical cystectomy.
Now, his creatine is 1.29. So, what is the clearance?
Sir, cisplatin eligibility usually takes creatinine above 2 in eligibility. So this patient has creatinine of 1.29. So we can like uh,
Yeah.
we can go.
Mahendra
It
bhai.
fits into the creatinine based therapy, sir.
So, this patient is falling into the criteria where you can give neoadjuvant chemotherapy.
Yes.
So, what are the criteria then?
Sir, we have to see the
Criteria
performance
for
score of patient.
creatinine. Criteria for cisplatin is creatinine clearance above 60 ml per minute.
Yes, sir.
Okay.
ECOG should be.
So I have never read a criteria which says up to two value.
Creatinine clearance must be more than 60, sir.
So can one of you just
Hamid
fast
said
calculate?
two and whatever less sir. ये 2 कहाँ लिखा है?
Yes, sir.
ECOG, sir. ECOG 2.
ECOG 2?
Yes.
ECOG, there is the criteria tells 5 points, sir. Cisplatin based chemotherapy, if you have to give, the patient should not have ECOG more than 2, and creatinine clearance less than 60, and more than 2 grade of angiometric loss, more than 2 grade of peripheral neuropathy, and in New York heart failure of class more than class 3. If these are there, then we should not use cisplatin based chemotherapy.
हाँ बराबर है.
Fine.
Yes, sir.
सर ये हो गया क्या? What is the rationale of giving NACT in bladder cancer?
नहीं वो ट्रायल्स नहीं पूछा है अभी तक.
नहीं ट्रायल नहीं, रेशनल मतलब क्या लॉजिक्स है?
No, you ask them ना.
नहीं पूछा है.
बताओ भाई.
Answer, Amit. Suhas, one of you please answer. Santosh.
You answered very quickly the cisplatin indications and contraindication. But now I'm asking about the logic behind giving neoadjuvant chemotherapy in bladder cancer.
It will downgrade. It will debulk the disease.
Okay, or
And
it will help to eradicate or reduce the micrometastasis.
okay.
Agree?
Yes, sir.
Second, because of reduction of stage, surgery becomes more easy.
Easier.
And the third, if the response CT scan, disease is progressing, that it is NACT is not working. So you can also see that whether when the you should not complete the NACT, and this is chemorefractory tumor. That means adjuvant में भी chemo काम नहीं करेगा.
Okay.
Yes,
You take it.
So the last one is the most important. कि आपने ये नहीं कि आपने नीट में शुरू कर दिया and you will continue till 4th cycle. Always there is a response scan between the chemotherapy to see the effect of it.
Okay. So we
So
should not even give a adjuvant. Okay.
yeah, so 3-1 have a clinical benefit, and the 4th one is where you should not continue the neoadjuvant chemotherapy. So examiner may ask if you start chemotherapy and when you will like to interrupt or in between you stop the chemotherapy. The answer is this: in response scan, if disease is not responding or progressing, that means indication of upfront cystectomy if feasible.
So, but Hamid, why you want to give adjuvant chemotherapy? What is an advantage of giving adjuvant chemotherapy? I mean, neoadjuvant chemotherapy.
New adjuvants are the same.
Neoadjuvant, why you want to give?
Now, this is something trial based. ये तो logic हो गया, rational हो गया. Okay. Asking the evidence about it.
What is an evidence? Why you want to give? And when you will not give, even though it has got benefit. So what is the benefit?
Survival benefit.
Chemotherapy has like survival advantage of like 5 to 6%.
Okay, 5%, fine.
It has pathological complete response is
Complete
seen
response.
in around
30 to 40%.
in 25 to 35% patients.
Okay, so now Habib has said he wants to give neoadjuvant therapy and then he wants to go for a radical cystectomy. Suhas, what you will like to do?
So I would also go with the same, so neoadjuvant chemotherapy followed by RC. That was it.
Suppose this patient is not fit. His creatinine is now raised. His clearance is less than 60. Or he is 80 years old. What do you like to do?
Multimodality
Is
therapy,
80
sir.
Pardon?
Multimodality therapy, sir.
Multimodality. So what you will do?
No.
TURBT, how much ever possible we do, sir. Then chemotherapy and radiotherapy, sir.
Sir,
So there are
scenario which you said was the same patient or different? Matlab same
Different. I'm
patient,
just asking him. I'm
same
just asking
patient,
him.
80-year-old.
No, this
If the
patient is
patient is not
74
fit for
years
the
old.
RC.
No, I just wanted to ask him that suppose instead of 74, if this patient is 80 years old, otherwise he is fit. So will you like to give neoadjuvant therapy or upfront you will like to do radical cystectomy? Or patient is continuously bleeding and he is going into clot retention. So is there any indication for not giving neoadjuvant chemotherapy and going for upfront radical cystectomy?
So intractable bleeding.
So technically, if it
Yeah,
is,
Ganesh bhai, you please explain them.
it is T2,
Basically, I want them to understand when they can go for upfront radical cystectomy and
RC.
may not wait for neoadjuvant
see, if a
chemotherapy.
patient like this is having hematuria, you can obviously scope the patient and try to stop the hematuria. I think if it is bleeding from any lesion, finally with TURBT or endoscopic management, the bleeding is going to stop. Very rarely the bleeding doesn't stop. In that case, if we want to stop the bleeding, we can always give a hemostatic radiation.
Yes.
Okay.
They give a single 5 gray or a 8 gray, which is a very high intensity radiation. But what it does is it causes thrombosis in the vessels of the tumor. And that is how it achieves the hemostasis. Vessels मतलब papillary tumor के या फिर solid tumor के capillaries में.
Yes.
And then the question was about what sir asked us. neoadjuvant chemotherapy. So neoadjuvant chemotherapy trials are discussed in T2 to T4A, N0, M0. What you people are mixing is N plus. So this neoadjuvant has been discussed in T2 to T4A, N0, M0, where it has shown benefit, where that Vesper study I said also showed benefit. Okay. Now the ABC meta-analysis for adjuvant also shows 5% benefit. Coming back to neoadjuvant therapy, if N plus disease is there, in most literature, it is either called perioperative chemotherapy or downstaging chemotherapy. Many people mistake this for a neoadjuvant chemotherapy. Okay. So that is it. So in any patient, T2 to T4A chemotherapy, neoadjuvant chemotherapy can be given. In specifically, this has been presented in ASCO also. If there are T2 patients, sometimes there are pros and cons of giving neoadjuvant chemotherapy. The pros we obviously know. It acts systemically, can kill the cells in circulation. It will downstage the tumor. It will overall downstage the disease, and then you can do the surgery. What happens is sometimes when you do surgery, patients take a long time to recover. And if this patient needs chemotherapy, then the adjuvant is delayed. These are all the pros with neoadjuvant chemotherapy. The cons are neoadjuvant chemotherapy itself can be effective, in some cases not effective. So usually after 2 cycles, you recheck the whole imaging. If the disease is stable or increasing, then obviously you give up and you might have to operate. Another cons is the side effects of chemotherapy. There are a good 15 to 30% patients who will have some side effects of chemotherapy. In a reverse manner, it can also cause an effect to the timing of the surgery. So these are pros and cons of neoadjuvant chemotherapy. Again, they also say that the quality of life of patient receiving neoadjuvant chemotherapy also decreases a little.
So you should be knowing all these answers when you are talking in exam.
But overall guidelines would prefer a neoadjuvant chemotherapy in T2 to T4A, N0, M0.
Yes.
So Ganesh, in this case, what should be done?
Sir, this case is T4A. इसको N plus बोलना मुश्किल है because they have not given the short axis diameter. They have said centimeter and sub-centimeter nodes. On basis of that, we can offer neoadjuvant chemotherapy after a proper TUR biopsy, which says that it is urothelial and not a variant.
Okay, fine.
Which is written here, high-grade papillary urothelial carcinoma.
Yeah.
So we can offer neoadjuvant chemotherapy in this particular case.
So 2 or 3? 2 and again see the response.
Sir, usually 4 cycles are planned, and usually any medical oncologist will see a response assessment after 2 cycles.
Fine. So this is all of you have understood, Hami?
Yes.
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 So
See, understand
question
one thing.
remains is which are the patients you will choose for bladder preservation, because somebody was talking about radiation and somebody was talking about multimodal therapy. What do you mean by multimodal therapy? If you have seen the evolution of bladder preservation is the broad topic given when you are going to preserve the bladder. So there are various ways when bladder preservation was evolved. A simplest thing was doing a partial cystectomy, which was not so accepted. The other thing was doing a TURBT and giving radiotherapy, doing a TURBT and giving chemotherapy. There have been past studies where only chemotherapy was given, only radiotherapy was given. And the more successful therapy was a trimodality. Trimodality involves maximal TURBT, sensitizing chemotherapy, and radiation along with that chemotherapy. Radiation to the bladder, prostate, and nodes. That is what. And there was something which is called as a tetramodality. Why tetramodality came into the picture was 10% of the people who were given trimodality had local recurrence. And 2% of these people had even lymph node positivity in larger series. So tetramodality was thought, in which after trimodality, the bladder was mapped as initial where the tumor was there. surgery was done, and a partial cystectomy of that area along with bilateral pelvic lymph node dissection was done. So this is 3 modalities plus 1 modality. Okay. So I think
Okay.
I have told something about bladder preservation also. Question to you guys was, which patients can be selected for bladder preservation?
चलो
The question
संतोष
is
answer
contraindication,
first.
sir.
Hmm?
Question is contraindication, sir. I could. Sorry, sir. I
Your
didn't
voice is
get-
not audible.
Question is contraindication, sir.
No. Inclusion criteria, indication.
Patient should not have hydronephrosis, sir. And
Okay.
multifocal disease is not. We should not. Should
Small
not
solitary
be.
lesion.
And if it is T3 and above, we should not give the bladder preservation. And CIS, we should not, as it is diffuse.
So in one line, if I say, preferably
Hydronephrosis,
not
CIS.
multiple tumors with
Yes, sir.
CIS and those tumors causing hydroureteronephrosis. Preferably
Yes.
single tumor. So these are the set of patients who do probably as well as the best series in cystectomy. Hottman had given a data about 1100 patients of a cystectomy where the 5-year survival was 67%. So the bladder preservation data in this well-selected cohort kind of matches this data or does slightly better than Hottman data. Okay. But the problem is that with this severe selection, it matches or does slightly better. If we do surgery in this well-selected group, it surpasses the percentage which is brought out by bladder preservation. I hope you understood what I said.
Okay.
Have you understood?
We apply the same
Yes, sir.
stringent selection criteria which a radiation oncologist applies and selects his patient. If we apply the same in doing surgery, then the rates of surgery go very, very high. The 5-year survival, they can go as high as 5-year 85%. So important thing is there is a lot of selection bias in either of the modalities. So today, which patient I will send for bladder preservation or counsel? There are 2 types of patients. One is a very well selected patient, or then a patient who is not fit for my surgery. Either of the two can go for bladder preservation. I hope these 2 things are very clear. Remember that much only for your exam. Sensitizing chemotherapy is given by cisplatin, gemcitabine, very rarely by mitomycin.
Fine.
5-fluorouracil, we should not use it.
Hmm?
5-fluoro is also.
5-fluorouracil is not given nowadays.
So you people have understood now what Dr. Ganesh is trying to
I am
tell
trying
you.
to tell you something between bladder preservation and radical cystectomy. So
That
Yes,
because
do you
whatever their criteria are there for a bladder preservation, if the same criteria are used, then the radical cystectomy will have much better
5 years
overall
survival.
survival. Understood?
Yes.
So ideally you cannot compare.
So you
Yes,
have
sir.
given neoadjuvant chemotherapy, there is a very small or minimal downsizing. What will you do next?
So go ahead with radical cystectomy.
Okay, you do a radical cystectomy open. What is your choice of urinary diversion and why?
In this case, please, the tumor is invading what?
The left ureteric column.
It is going into the
Prostate, base of the prostate, and
Prostate. Prostate is in. Yes, sir.
Okay, suppose it would not have gone to the base of prostate, it was the simple T2 tumor. What would it be? How would you decide, or what would be your choice of doing a diversion?
sir, considering his
Basically, I want to
age,
know 2 things. Which diversion is preferable? What is the quality of life data?
considering his age, we can counsel him for the conduit, sir.
Conduit.
And considering his creatinine? Okay, what are the contraindications of doing ONB? चलो ऐसे नहीं तो वैसे आंसर दो फटाफट. ब्लैडर का क्लास होने वाला था, पता था ना. Somebody who is putting messages on the chat, at least वो तो पढ़ रहा है.
If creat is more than 1.6, we should not do so. ONB.
Anyone from the audience wants to answer?
So creat should be less than 2. And GFR of greater than 35.
So Hamid, just tell us what is your choice of diversion. Then just give the reason, na?
Sir, considering age and creatinine, I would like to go with the conduit, sir.
So you like to do islet conduit?
Yes, sir.
Okay. Santosh, what you will like to do?
Orthotopic neobladder for this patient cannot be done, sir. So I also go with islet conduit, sir.
So which one?
Islet conduit only, sir.
Islet conduit.
Islet.
Okay. So all of you are agreeing with the islet conduit.
But why so? Islet conduit only? Everybody?
Yes.
Quality of life ONB versus ileal conduit.
चलो बोलो.
इतना तो सवाल आएगा एग्जाम. Why would you prefer something? Why would you prefer something? So I will say institute protocol, or in my expertise, I will do ileal conduit. But then I will ask this question as examiner. What is the difference in QOL?
Ganesh, you can just tell them what answer they should give in exam when such a question is asked.
So earlier when ONB was initiated, the quality of life was thought to be much better with ONB. Now the quality of life is almost near equal, but ONB is still slightly superior except for one problem, which is a nighttime incontinence, which can happen in a few people. Nighttime incontinence. So with respect to nighttime incontinence, and ONB patients carry a slightly better body image. So these are two things which score over the ileal conduit, and that is why they are not grossly different, but ONB scores a little better, very little better than the IC. So that is what you remember.
Understood, all three of you?
Why you
Yes,
all
sir.
people are too much confused throughout the exam, throughout the discussion? Because
Sir, sorry, sir. Sir, since his
since
bladder
starting,
is involved, sir.
Listen. Since starting, in spite of knowing you are getting problem in the asking, answering that simple questions. Everybody is confused. So, what are the differential diagnoses? Only save lab. When to do only a CT scan prior to the biopsy, after the biopsy, indication clear cut लिखे हुए उसमें confusion. Biopsy करना है तो complete TURB टिकअप करना है. Whenever possible, do complete TURB. Simplified answer. बायोप्सी कब करना है? सिर्फ सुपरफिशियल चार चीज निकालने से क्या मिलेगा आपको? When to do cytology, upfront cystectomy कब करना है? Each and every question today is confused, and confusion is still going on. When to do a MRI, when to do a CT scan. Already there are clear-cut indications. ये हर आप कब जाएंगे न्यू एडजुवेंट कीमोथेरेपी को? अगर आपको सिटी स्कैन कब करना है, उसका आंसर आया। एग्जाम का प्रिपरेशन है ना, तो वहां पहुंचने के लिए पहले बहुत सारे स्टेजेस जाना पड़ेगा। क्लियर कट है ना, मल्टीपल पॉलीपॉइडल ट्यूमर है, ब्रॉड बेस्ड है, क्यों नहीं करना सिटी स्कैन पहले? सिंगल ट्यूमर है, छोटा सा ट्यूमर है, पेडम्प्लेटेड है, क्या जरूरत है ट्यूमर सिटी स्कैन पहले करने की? ये सब 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 क्लियर कट है, उसमें कंफ्यूजन होना ही नहीं। तो एग्जामिनर ने पूछा कि टिप ऑफ टंग पे फटाफट चीजें आ जाना चाहिए। आइलियल कंडक्ट क्यों करना पूछ रहे हैं, ये पेशेंट में कहाँ कहाँ ट्यूमर है, उसका ब्लैडर के पास कितना क्लोजनेस है, उसका स्टेज क्या है। तो टोटली जस्ट डिस्कशन गोइंग ऑन। ये हर एक क्वेश्चन, ये क्वेश्चन को इतना डिफिकल्टी क्यों आना चाहिए? तुमको सिस्टोस्कोपी करे वाला है, सिस्टोस्कोपी में कहाँ ट्यूमर है पता है, सीटी में कहाँ ट्यूमर है पता है, कितना ट्यूमर है पता है। तो कैसे क्या ऑर्थोटोपिक न्यू ब्लैडर कर सकते इसमें? क्या है सीटी के रिपोर्ट में, क्या क्या प्रोस्टेटिक यूरेथ्रल बायोप्सी, ब्लैडर के पास कितना कितना नजदीक था, ये कौन पूछेगा? बेसिक में अगर राडा रहने के साथ आपको कितना भी अपफ्रंट आगे का आ गया, तो वहां तक जाएगा ही नहीं केस। तो मेरा क्लियर कट सबको एडवाइस है कि जो बेसिक क्वेश्चन है डे टू डे एग्जाम में पूछने वाले, उसमें एट एनी कॉस्ट कंफ्यूजन रहना नहीं चाहिए, और है तो यही के यही क्लियर करो।
So you understood one small thing, what Dr. Gite is saying.
Yeah.
For example, you ask for a biopsy. So in that biopsy, you should have said that I would like to do cystoscopy, I like to see urethra, I like to see prostate. Then which are the places where you take the biopsy, and you ask the presenter in cystoscopy what were the findings, and then depending on that, yes. So in this case, there is something different. And Dr. Ganesh Bakshi had asked you that if it is not involving the prostate, if it is the tumor, small tumor invading the muscle, then what are the options? So if it is an individual case
में भी सर क्लियर कट एमआरआई करना कि नहीं करना, क्यों करना है एमआरआई? ऑलरेडी तुम्हारा सिटी बता रहा है बाहर गया है, सब सेंटीमीटर 1 सेंटीमीटर के नोड है, वहां पे प्लूरल इफ्यूजन है, उसका कुछ हुआ नहीं है। वो हाइड्रोनेफ्रोसिस का क्या क्या उसका कुछ पता नहीं है, क्रिएटिनिन कम क्या नहीं किया वो डिस्कशन हुआ नहीं है।
So now
I don't know कि मुझे हाउ ये ऐसा ही परफॉर्मेंस रहा तो आई एम नॉट गोइंग टू पास यू पीपल।
Yeah. No, that is why we are, Dr. Gite. So this is the time when we have to explain them how to answer in the exam. So now they are becoming wiser and wiser. So now at the end of this, when you explain them what are the important things, they should be very clear in their mind. The question is, have you seen multiple cases of CA bladder? Have you managed multiple cases? If the idea is that only, that we want to show you multiple cases, so that at the end of this session, all of you know what to answer in a particular case. That is very important. But there should be input from all of you. So when you go to the ward, please see everything like this only and decide.
सिंपलीफाइड है, आपको अगर सोनोग्राफी पे मल्टीपल पॉलीपॉइडल ब्रॉड बेस्ड ट्यूमर दिया है तो सीटी पूछते समय यू हैव टू आस्क डायरेक्टली सीटी एब्डोमेन पेनिस विद एचआरसीटी टेस्ट 1 गो में पूछना है। यहाँ कोई कंफ्यूजन है क्या? क्यों नहीं पूछा गया वो? आर यू हैप्पी विद ओनली एक्सरे? देन व्हाट आर द डिफिशिएंसीज ऑफ एक्सरे चेस्ट? ये पेशेंट में एक्सरे से काम चलेगा क्या? एग्जाम में हर छोटी छोटी चीजें प्लीज क्लेरिफाई करा लो यहीं पे, और चुप आगे डिस्कशन लेके जाने से अच्छा है कि यहाँ पे तुम क्लियर कट कब करना है एंटीरियर सिटी स्कैन, कब करना है पोस्टीरियर सिटी स्कैन, कब करना है बायोप्सी, व्हाट आर द इंडिकेशन फॉर न्यू आर्ट जॉइंट, व्हाट आर द इंडिकेशन फॉर आर्ट जॉइंट। ये सब चीजें वहां तक जाने के पहले कोई भी हिमेचुरिया के पेशेंट आए तो आपको सीधा 4 डायग्नोसिस ध्यान में नहीं आते। ट्यूमर है, ट्रॉमा है, इन्फेक्शन है, इंस्ट्रूमेंटेशन है, ऑपरेशन है, उसके बाद में ट्यूबरकुलोसिस है। ये चीजें टिप ऑफ टंग रहना चाहिए।
Agreed. I think hardly anybody discussed even tuberculosis today.
Yeah.
Okay. So anyways, matlab, whoever is listening to this, try to present or talk comprehensively. एक word बोल के चुप मत बैठो, मतलब. Try to answer as a full sentence. Try to cover all the points and try to say something basic. अभी बार-बार ये clinics लेके you also should try to understand that we are trying to inculcate something, some way of talking, some way of asking questions, some way of answering to the point. Be specific, save your time, save your own time in exam so that you can reach a logical discussion with your 4 examiners in your exam and they feel happy to give you marks. ठीक है?
नहीं सर, कैसा है, थोड़ा भी कंफ्यूजन होगा ना छोटी चीजों में, वहीं पे एग्जामिनर पकड़ लेता है और आगे जाने नहीं देता।
Absolutely.
तो अभी ये प्लेटफॉर्म मेरा सब स्टूडेंट से रिक्वेस्ट है, यूज दिस प्लेटफॉर्म टू क्लियर द आइडियाज। इट मे बी एनी सिली थिंग। जो चीज आपको पता नहीं है ना, यही पूछना है, हमको आगे जाने नहीं देना है। जब तक आपको वो चीज पक्की क्लियर कट पता नहीं चलती।
Fine. So at least now we have discussed with Dr. Ganesh and all, and we know what is the what we are supposed to do in this case. We'll like to do neoadjuvant chemotherapy. See, after 2 neoadjuvant chemotherapy, maximum 4, and then we know the advantages of that. We'll go ahead with the radical cystectomy, provided we know the status of the pleural effusion. Correct, Ganesh?
Yes, sir.
Yeah. Then what is the role of adjuvant chemotherapy? Can anyone answer fast?
Okay, in those patients in whom you cannot give, we discussed this. Actually, I explained you. Who are cisplatin ineligible, you are going to operate and have all these high risk factors. You would go for an adjuvant chemotherapy. Again, ABC meta-analysis says that there is 5% benefit.
Fine.
Again, 4 cycles you have to give. And by the end of that cycle, you will have to do a general follow-up or a response assessment again.
So before we conclude, just of course we have got other 2 cases of CA bladder, 2 or 3 cases. But how will you follow up this case after doing?
Hello, Hamid, how will you follow up the case?
3 monthly scan and
3 monthly.
3 monthly cystoscopy for first year, then 1 yearly for 5 years.
3 monthly for 1 year and 1 yearly for 5 years. नहीं समझा है, sorry.
Clear it out.
After surgery, we have to do the cystoscopy every 3 months.
Cystoscopy.
Cystoscopy bladder निकलने के बाद मतलब तुझे
Bladder तो निकल दिया है.
पद्म भूषण देना चाहिए, पद्म भूषण.
Post surgery, annually. Upper tract we have to see, and cytology.
2 डिवाइस से लॉगिन किया है तो वो एको हो रहा है, वादियों में बात कर रहे थे.
Yeah. Come on, Hamid, you can answer.
We'll follow up the
protocol is like 3 monthly for 2 years, followed by 6 monthly to complete 5 years, and then annually till 10
10
years.
years.
At least the interval. Another thing is what you are supposed to do, which investigations that follow. Right. So there is a that you answer. Certain CT scan at certain intervals, urine cytology, when, which blood tests. Tell me.
CT scans are will give a baseline CT at 3 months, and then accordingly we can do a CT scan at 1 year, followed by 6 monthly CT
6 months
for
का
further
बाबा
2
पहले
years.
2 साल
Sorry.
6 months है बाबा 2 साल
Yes, sir. For 2 years, then then yearly for 5 years. After 5 years, and we do the LFTs and chest X-ray.
Okay.
Yes, like the frequency will be like this: the baseline CT at 3 months, then at 1 year, then 6 monthly for 2 years, then yearly till 5 years, and this LFTs and the chest X-ray of similar frequencies. Sir, if anything found in chest X-ray, then we can do CT scan according to HRT.
देखो post surgery I will do evaluation on every follow up by clinical examination, evaluation for chest, evaluation for abdomen, and evaluation for the bowel what you use for the diversion. So if it is orthotopic no bladder, if it is ileal conduit, then what investigations, blood investigations like sodium, potassium, chloride, vitamin B12, how frequently there is a need of urine cytology. ये ऐसा सिस्टमैटिक अगर बता दिया ना तो एग्जामिनर विल गेट इम्प्रेस्ड. नहीं तो मैं सिटी स्कैन करूंगा 3 महीने को, फिर 6 महीने को, फिर 12 महीने को, फिर पेशेंट को कौन देखेगा? चेस्ट के लिए क्या कौन सा सिटी स्कैन करेंगे?
So Hamid, can you now just gather everything and can tell us now in one line? Dr. Gite has given you a beautiful summarized answer. Just tell us.
Okay.
Sir, we'll,
before you answer,
yes, sir.
Something like if you do ileal conduit, the urethra also needs to be looked into.
Yeah. In this case, you will have to do the urethrectomy also. This case.
Barabar.
So that we have to remember.
Yes, sir.
Fine. So now
Yes.
answer. Before we close down, you just finally tell us how we are going to follow.
I'll do like serial clinical examination along with the blood
In the
investigations.
clinical examination, what we'll see? First of all, you like to see how is the conduit.
Conduit, yes.
Then about the incision, whether there is any herniation is there or not. Correct?
Yes.
And then along with that, you will see all the lymph nodes, whether there are generalized lymphadenopathy is there or not. Correct?
Yes.
And if you have not removed the urethra, you like to see the urethra also. Or any other lump, anything palpable in the abdomen. That is a clinical examination. That is number one. So every time patient comes, you are going to do clinical examination. Second thing is, what blood investigation you like to do?
LFT serum electrolytes and LFT serum electrolytes, and for
so you like to do
bone,
investigation for the tumor, correct? Malignancy, as well as you are already done the ileal conduit, so you want to see what is an effect of that ileal conduit on the metabolism. Correct? So what are the things you'll do? You'll do LFT and you'll do electrolytes. Plus
electrolytes, yes.
Then you already done the
bone
anastomosis. You've done the anastomosis. There are chances of obstruction.
Creatinine.
Oh, renal, right, renal function test. So you like to do this exam test and CVC. There may be some infection
LC.
also.
Yes.
So how often you will do it?
For 1 year, for first year, every 3 months. Then for
So 3 months and as per needed. Fine. Okay, that is the answer. Then whether you like to do sonography, CT scan or PET scan.
Sir, I would like to do a baseline CT scan at 3 months, and I'll do a PET scan at 3 months, and accordingly I will advise patient for the CT scan at 6 months interval for 2 years.
And along with that, you like to do X-ray chest also?
HRCT, HRCT chest.
Fine. Ganesh, you want to add something?
No, sir, ठीक है मतलब. I think slightly what you need to do is everybody, you need to go through the EAU guidelines. The follow-up protocol schedule is given very nicely. So remember, it's
So we are still going to have 2 cases. So please next time,
we
as
can
Dr.
continue
Gite
bladder,
said,
CA bladder next time actually.
yeah, we'll continue CA bladder.
Because I think people look tired.
Yeah. No, we
Students
have
are
got
not
a
talking only.
non-invasive. We have got a non-invasive and even the metastatic. So we will go through all these things.
Okay.
But next time, please, or those who are answering, please remember what Dr. Gite has said. Okay.
सर मेरा रिक्वेस्ट यही है कि उनको कोई भी एकदम यूजलेस थिंग भी अगर नहीं आ रही तो हमको पूछने के लिए बोलो. हमको पता नहीं है तो हम बुक में पढ़ के उनको बताएंगे.
लेकिन सर एक और चीज है कि एकदम बेसिक भी ना पूछे कि जो वो आराम से मिल सकता है. somebody asked about the grading of prostatomegaly and various things जो है. So these things are can be find anywhere कि PR फाइंडिंग में क्या क्या चीजें होती है, MS लेवल की चीजें होती है.
महेंद्र जी कैसा है कि वो समझो फॉर एग्जांपल प्रोस्टेटिक ग्रेडिंग फिर वो पर रेक्टल पे है, एंडोस्कोपी पे है, सोनोग्राफी पे है, ट्रांसरेक्टल सोनोग्राफी पे, वहां कोई एक आधा बूढ़ा आदमी बैठ गया तो वहां अटका देंगे. तो ये मेरे हिसाब से ये जब पहला क्लास रहेगा तो एक बार बोल देना, दूसरे क्लास में फिर उसको आगे बाईपास करना.
हाँ सर, मेरा वही है कि एक ही क्वेश्चन हर क्लास में रिपीट नहीं होना चाहिए.
नहीं होना चाहिए.
जो स्टूडेंट सर उसमें होता क्या है कि
अगर ये सीए ब्लैडर इतना डेप्थ में अगर डिस्कस हुआ है तो नेक्स्ट सीए ब्लैडर में क्लिनिकल हिस्ट्री पे आगे चले जाए.
नहीं तो we don't end up completing the whole spectrum of the topic.
We will not progress. We will spend 20 minutes only history only.
No. Now that is what we are doing. We will not have history in detail.
बट क्या है कि 3 केस अगर है तो एटलीस्ट एक केस को बेसिक केस से लेना चाहिए.
बराबर है.
Yes. Right. So we'll do the same thing. Next time history will be very fast and then investigations and we'll just go ahead. Okay? More of the discussion and we request all the students please read.
Just to पढ़ के तो आएंगे, but some tips to the students. ये रिस्क स्ट्रेटिफिकेशन में ये ध्यान देना, लो रिस्क है कि हाई रिस्क है. It need to be present all components or only one components, 2 components to make the risk stratification. And again कुछ organs के जो follow up होते हैं, they also based on risk stratification. लो रिस्क है तो 6 monthly follow up है, हाई रिस्क है तो 3 monthly follow up है, and also the investigation changes with the risk stratification. So please focus on all those points also while preparing for the exam.
Right. Thank you, Mahendra. So we'll continue next time. Okay.
Yeah.
With a
good night.
Good night.
Good night, Gite sir.
Good night, Gite. Good night.